Welcome to Clinic Success Secret, where we uncover the strategies and insights that drive clinic growth and excellence in patient care. Join us today as we dive into getting some real expert advice from our guest today, Nirmal Kaur, and find out what she's been doing to help cause innovation in the clinic space. So, first of all, uh, I'd love to give our guest a introduction that she deserves. Dr. Nirmal Kaur is a distinguished gastroenterologist who has dedicated her career to advancing the field of inflammatory bowel disease, including Crohn's disease, uh, ulcerative colitis, and other intestinal diseases. She began her medicine journey in the State University of New York, where she earned her medical degree in 2004. Since then, she has been honing her expertise with a residency in internal medicine and a fellowship in gastroenterology at the prestigious University of Michigan. And today she serves as the director of Inflammatory Bowel Disease Center and the medical director of the referring physician office at the one and only Henry Ford Health. Her core philosophy is one that really resonates deeply with our mission at Clinic Success Secret and Clinic Success Partners, as she believes that, as with many other guests that we've had, that good healthcare really involves both physical and psychological components, addressing both to foster strong patient-doctor relationships. And this not only improves patient outcomes, but also strengthens the overall healthcare model. So listen, I could go deep on this, but that being said, uh, Dr. Kaur, it's an absolute pleasure to have you on. Appreciate it.
Thank you for having me, Timon.
First of all, Dr. Kaur, I'd love to dive deep into what you do today. I know you're putting a lot of focus on cooperative care models, and I think we've talked about this before, and I think really the future of healthcare is, number one, viewing things holistically, two is education, but also three, building those relationships both with patients and other medical professionals. So could you please explain what cooperative care models are and how they may differ from traditional healthcare delivery methods?
Certainly, I appreciate the nuance of the question. Ultimately, like you mentioned, Tomas, my background is in inflammatory bowel disease, and I spent the first chapter of my career building out the Henry Ford Health Center for Inflammatory Bowel Disease. And through that experience, really saw the impact of patient access on patient outcomes. For example, if a patient with Crohn's disease was able to get care at a tertiary inflammatory bowel disease center, like we established at Henry Ford Health, then their ability to stay in the workforce, minimize disability, was significantly improved. And what I found through that experience is that the cooperation between the community physicians, whether they're gastroenterologists or primary physicians, that cooperation between those community physicians and the tertiary care specialists, that was the key to success to improving the lives of many of those patients. So I spread my wings to the referring physician office leadership from 2020 to 2024, as you discussed, and was able to execute that work on behalf of a number of Henry Ford specialty areas. We actually ultimately offered this type of cooperative care across 22 specialties involving over 60 physicians. And the cooperative care delivery model, what it means is that the patient's care stays local as much as possible. I'll use the example here in Michigan. The rural community, maybe 100 miles outside of Detroit on average, does have a number of clinical services that are useful to the patient: radiology, imaging, laboratory studies. Sometimes some of those cities also offer procedural services. But the complex tertiary care that was required a system like Henry Ford Health or something similar, required the patient to come to Metro Detroit for that experience. But the bulk of that care could be kept local. So if I'm a patient and I've got severe Crohn's disease and I need 10 tests and possibly a surgery, oftentimes at least 8 or 9 of those tests could happen closer to my home. So the cooperative care delivery model involves physicians and healthcare organizations connecting so that the patient's care is executed at the most convenient location for the patient. Going back to that same example, if that patient with Crohn's disease got 8 or 9 of those tests in their local community, we would facilitate the communication of those results to the tertiary specialist and coordinate their follow-up care by coordinating those two organizations. And then ultimately, a procedure or surgery that had to happen typically went on at the Henry Ford location. And by everyone working together, the patient was able to have improved outcomes. We're very excited. This work was actually recently accepted and published at the New England Journal of Medicine Catalyst, actually just ran last week. And the most exciting part of that is that the impact was found to be quite significant. And I'll delve into that, I'm sure, later in the podcast.
First of all, I want to say congratulations on last week. I saw it on LinkedIn. Very exciting times. And I'm looking forward to you getting to share with people what the outcome of those sort of insights were. Circling back again to the actual model itself, I mean, when we've talked in the past and you explained what you're doing with Syncora Health, I thought this is the most rational, obvious thing in the world to implement when said out loud. Have there been similar effort to keep this local before? You know, to me, it's not been a no-brainer. Why, especially if someone's unwell, why get them travel halfway across the country when there's a perfectly qualified person who you can, that's in your community that can help? Is there a history of this? Is this new? What's that looking like?
It's a great question, Tomas. My 12-year-old put it best, when I explained to her what I was doing. And she looked at me and said, "So you got people to collaborate? Why is that? Why would anyone find that exciting?" What a really valid question from the innocent mind of a 12-year-old. And what I think it speaks to is the fact that healthcare has become very siloed. And if a patient needs care, then oftentimes the healthcare organization executing that care keeps all of it in-house, potentially not acknowledging that the patient's profoundly inconvenient. And I used to joke when I was having my kids that it's a part-time job being pregnant and having to coordinate that care and make time for that and travel to that care. And why is this so difficult? I'm just trying to have a baby. Why is this a part-time job? And to address your question, the interplay between healthcare organizations is unfortunately a novel concept in a lot of ways. Goes on a little bit, but in pockets. And pockets that, in my opinion, are a little too small, which is part of the reason I founded Syncora Health, to be a third-party facilitator to allow for collaboration between healthcare organizations, starting with the physicians who are in leadership at those organizations, so that the focus is on patient care. And the couple examples of the collaboration that goes on. One example is our National Veterans Affairs system. The Veterans Affairs, lovely, large national network, of course, serving the veterans of the United States. And in each of their markets, they typically collaborate with the local expertise. I trained at the University of Michigan, like you mentioned. Right there's the Ann Arbor VA. And the Ann Arbor VA, we did rotations there as trainees. The GI physicians come over to the Ann Arbor VA periodically and do procedures there. That's the type of model that I think we need to build upon at a larger scale in cities that don't have VAs, in for populations beyond our veterans populations, where healthcare organizations work together for the good of the patient. I think that that's what we need to get to. And that's one of the founding principles upon which we were basing Syncoro Health.
That's perfect. And then one thing as well you mentioned, because I just, as I said, this seems just so profoundly obvious, and I think the best ideas are obvious when they're said out loud. Ba- Building on that concept of you know, like the lack of an integration, the lack of fact that everything's segmented currently. I think it's obviously you'd be remiss of me not to mention the second order benefits of keeping things local and the cooperative healthcare approach. You do mention the importance of addressing both physical and psychological consideration um, in healthcare. How exactly does Syncoro Health integrate mental health considerations into its cooperative care model, and what benefits have you observed from this holistic approach?
Uh, Mental health, I think, plays a much more massive role than we acknowledge. I think with COVID, we're acknowledging a bit more than in the past. Um, but it's very much the elephant in the room frequently. Many larger health systems, tertiary referral centers, have behavioral health or mental health care as a part of their multidisciplinary programs. I always go back to my Crohn's and ulcerative colitis examples because it's what I did for the first 12 years of my career. But we involved a health psychologist. She's a PhD in psychology into our multidisciplinary clinical service. And the effect of that mental health care on our patient population, immense. And the beauty of this is that there was also a positive effect on the staff. We found that our nursing teams, our medical assistants, our secretaries, even us physicians, we found that her effect on the patient population, it was palpable. Some names, when we see that individual's name on our schedule, induced anxiety in everybody because we knew there was always a large mental health burden coming in with that individual. But as the psychologist became a part of the team, kind of embedded into our practices, and we established the pathways by which to get patients to her, the effect was profoundly noticeable. I wish we had the capacity to have mental health care everywhere, Tomas. We unfortunately do not. But in pockets where it does occur, it can occur virtually. And where the digital divide is present, which is larger than we've realized as a country, the psychologist often did phone visits with a patient, which maybe is not as ideal from the standpoint of human connection, but at least offered something. And offering tentacles on that service, why would that mental health coverage only be in the big city or only be at the center where that service is present? It's virtual. It can go on via phone. Why not have that go on as much as possible? So I think that should be that's a key factor in connecting healthcare organizations, is to offer mental health as a part of specialty service care.
Perfect. And then building on that, obviously, Nirmal, how, I mean, as in the room, we talked about it. How do you go about this? Several questions I'd like to ask, but what are some key strategies for successfully implementing cooperative care models in both tertiary and community hospital settings? You know, how does that look? Well, what are some inside
Yeah.
tips to making it work?
So the main one is connect the people in charge. Who's in charge of the patient care? The physicians. Connect those individuals because those are the two individuals who really know what that patient really needs. So what we did over the years is we would go and have dinner with our referring physicians at least every year, touch base and connect. Once we had an established relationship, maybe sometimes it was every 6 months. But that model that I have to give Henry Ford credit for, going out and connecting with those individuals and making sure that those two people who are in charge are in each other's phones and can communicate in a very streamlined fashion so that support team to facilitate those communications, that is critical for that patient's referral to come in a smooth fashion and for that patient's care to be executed in an appropriate fashion for that patient. So that is something that some healthcare organizations execute beautifully, and some healthcare organizations could use assistance with. And connecting those organizations together is something that is profoundly effective and is one of the main missions of Syncoro Health.
Beautiful. And then in terms of best practices for actually making this happen, Nirmal, um, are there any best practices for establishing and maintaining? You mentioned obviously meeting up in person, making sure the decision makers, as you said, are accessible through phone and so on. But are there any other best practices for establishing and maintaining effective partnerships between these different healthcare entities?
For sure. And the most important thing here is that the specialty physicians really profoundly respect the community physician's territory, because I think you were starting to touch on it, Tomas. There are dollars involved. There's revenue from healthcare in the community. There's revenue from the procedures and surgeries and services that go on at any system. And making sure that that community physician feels very comfortable with where that care lands, that is key. Because if that community physician feels like they're being encroached upon or their business stream is going to be cut off or decreased, that's not going to be healthy for the relationship between those two to allow for that interplay. We have to acknowledge that healthcare, particularly in the United States, is a large industry where revenue is at stake. Making sure that community physicians are very comfortable with the care that is being referred out. That's the key to success here for every part of this work, for the patient, for the tertiary specialty organization. That connection and nuance is important it's important that it's navigated by a medical specialist. I'll go back to the example in gastroenterology. I must have said it ad nauseum a million times to our community physicians. We're not here to take your bread and butter. We're not here to step on your toes. We are here to help as you see fit, doctor. And you are in charge of all of this. And we will return the patient to your very capable care once we are done with the service that you suggest. That's key. That's the key to life here. And I think that can easily become a diluted message that has to be brought back to the surface again and again in order for everyone to feel comfortable.
Great. I think what you're touching on there, it brings back to you actually, I think you said it jokingly, but I suspect not that jokingly, saying it's the key to life. I think, the concepts here that you're talking about, you really are, they're universal. As I said, as every area of life, the quality of your life is dictated by the quality of your relationships, and same principles apply. How do you build respect? How do you build trust? It can be business, it could be platonic, it could be romantic, whatever. It's the same fundamental. Um, Plenty of ways I want to segue off that, but how do you go about building that trust specifically? I know you said it's nice to say in an idealistic world, we'll grab dinner, we'll pop phone details, and we'll trust each other in good faith. But game theory and plenty of other things would indicate that
Sure.
people always indicate often act in the self interest. How do you combat that?
Yeah. And what you do is you practice what you preach. And a patient is referred to a specialist for, say, a singular service. You, as the specialist, you execute that singular service. You communicate to the person, you communicate to the local community physician who was so gracious to provide you with any trust, any business. You communicate immediately. You follow through on what you said you'd do. You return the patient back, and doesn't hurt when you tell the patient how great their community doctor is. It's it's business 101 with medical care on top of it. But you execute what you said you'd do, and you communicate that back, and you practice what you preach. It doesn't happen overnight, but you continue to do that, and you build some trust equity. And that's a slow moving ship to ultimately develop a tertiary care referral center where you're doing this at a very large scale and impacting thousands of lives, and everyone's bottom line is better. And most importantly, the patient's life is better. I think that's how you go about it. Starting with, like anything, mission focus. Mission focus for the good of the patient. And the revenue in the business is executed, but it's a secondary consideration to the patient's care. And that's something that I think the field of healthcare sometimes needs a reminder on.
I love what you're saying there. I mean, fundamentally, in a nutshell, is that there's no shortcut. Trust, by its very definition, is based on evidence, and evidence is a factor of time. So take your time, actually spend the time getting to know those relationships, and the trust will inevitably come as a byproduct when the case study, so to speak, or the evidence is given to each other. So I like that. It's just super basic, but basic works. The fundamentals of anything. You touched on something there, Nirmal, with regards to specialists in different areas. And again, I love the point that you're making about constantly bringing back, and hey, listen, your local facility or doctor is amazing. Just making sure that that respect is there. But on the topic of specialists, what role do multidisciplinary teams play in this whole cooperative care delivery dynamic? And how can clinics actually effectively build and manage those teams?
So I think ultimately multidisciplinary care is an increasingly a requirement for a lot of medical care. Um, Tomas, I trained back in 2004 to 2010, and we had some multidisciplinary teams for, of course, complex cancer care. Um, and the concept of multidisciplinary care for inflammatory bowel disease was kind of just beginning because there was only so much nuance in therapy development or surgical development. But right around 2008, 9, 10 is when these complex inflammatory bowel disease centers started coming up around the country because the advancements of the field were so great that the general gastroenterologist, not all, but some would say, geez, this is getting to be a lot. Let, let's refer patients to dedicated multidisciplinary care, collaborating with colorectal surgery, pharmacy care. Sometimes you need nutrition teams involved as the availability of therapies become uh, so robust. That led to the increasing development of multidisciplinary care. And frequently that goes on in larger healthcare organizations where all of these services are possible. There are pockets where private groups or smaller organizations are able to pull off multidisciplinary care, and my hats go off to them, but that's not the norm as much so. Oftentimes it's in, I'll even say, academic centers. Sometimes those things are easy to pull off. One example, transplant teams, by definition, have pharmacy, specialty surgeons, transplant surgeons, specialty care in organs that are being transplanted. The transplant services are often only at academic centers, or largely only at academic centers. So piggybacking onto that model, multidisciplinary care is something that typically goes on at a transplant center. But the number of those are not sufficient to serve the population across all geographies. So patients travel quite a distance for multidisciplinary care. And I think, many of us call it a silver lining in COVID to execute that at a more convenient location. But that's one of the things that we were able to accomplish through my work at Henry Ford, and we're now trying to do through Syncoro Health.
Brilliant. And again, oh, on the topic of the work that's been done at Syncoro Health, I definitely do want to circle back in a minute about the work, the news that came out last week that we touched on earlier on. But before we bring that up, again, just for the people that are listening here, they're running clinics of different sorts. There may be some that may be more on the aesthetic side of things, but there are definitely some people that are on the all the types of healthcare similar to what you're talking about. That would definitely benefit from the cooperative care model that we're talking about. So for those people, as you mentioned, at the end of the day, healthcare, especially in America, is a business. How can implementing cooperative care model impact the financial performance and growth of the clinic?
I think a lot of leaders' knee-jerk response is, if we don't keep all of their care here, then we're going to lose money. And that is, I think, one of the reasons that cooperative care does not go on as much as it could. But the beauty here, Tomas, is that we found that because care was more convenient, new business arose. So I'm one of the lucky providers that gets to see a patient who will say directly to me, I didn't know that I could get care for my Crohn's disease in my community. So I didn't get care for the last 10 or 20 years. And I just kind of made life work. And of course, you can imagine the mental health impact or the side effects of not getting care for a chronic disease. The outcomes of that have a different trajectory. But because of the cooperative care delivery model, patients who were not previously seeking care are now seeking care because they can, because it's more convenient. So there's actually more business for everybody. We have a very sick population. And I always internally cringe a bit when I say the word business, but we have to acknowledge that there's a financial part here. But when access is so bad, many people are just out there suffering. And a cooperative care delivery model will allow for new music to come in financially. And that's the part that I think it's very hard to measure, but it's there, and the volumes demonstrated in the New England Journal of Medicine Catalyst article last week are a testament to that.
I love that. There's an interesting parallel there where, in my world, in the digital marketing agency world, you see very often people are like, right, if I, there's a, same but different kind of thing, where people will be like, right, if I only help one type of business, I'm turning my nose up at all these other things. I can't afford to send things other people's way. But as you said, the overall volume um, that or people that will come to you out of convenience is a net positive. And, at the end of the day, what's beautiful about what you're doing is it's fundamentally more people just taking care of their health. So I think that's great. The output is you get to do what you do best, get help more people and more patients. Because as Ken Mitchell, the previous guest, always said, you take care of the patient, the revenue will take care of itself.
Oh, I love that line. That's a fantastic line. I'm going to borrow it.
So Ken Mitchell, if you're listening to this, for the record, I have given you credit here, Mister.
That's a great line, Tomas. Okay.
I'll introduce you guys as they get along very well. But Ken, if you're listening, I did say it's from you, for the record. Um, Bring it back to the other side of things, then obviously, more business comes in. Are there cost savings that are associated with clinics if they're leveraging this cooperative care delivery?
Cost savings, harder to quantify, honestly. The care that's executed lands both in the community, lands at the tertiary care specialization. Cost savings is really societally
The
because
patients, yeah.
the patient misses less work. The
Right.
patient is showing up at their job more often because they didn't have to call in sick. That's the cost savings. Another aspect, the patient is not in the hospital or the ER as much because they're getting their appropriate care. They're plugged in with the healthcare that needs to be happening, and they're honestly just living a better life. And that's the outcome I wanted to share from the New England paper that just came out last week. Um, we were able to demonstrate that because of the intervention that we did with this cooperative care delivery model, we reduced hospitalizations and ER visits by 67%. And the numbers there, it was an average of 1.8 hospitalizations or ER visits per year that reduced after we did this intervention to 0.6. If you think about that, I like to think I'm the patient and think of that life. If I'm going to the ER or the hospital 1.8 times per year, so almost 2 times per year, that's a pretty rough life. Your day-to-day is not so great. If you probably need to call in sick a decent amount to your job. But reducing that to 0.6, we don't have this piece of data yet, Tomas, but the team is currently studying it. Work productivity index. My hunch is that we've kept people in the workforce more. So that's the real cost savings is societally. Does cost savings land at an organization? Not so much. We share the revenue between organizations.
I love that. And then I remember you told me about this before, and I got really excited. Are there any other insight from the article in the New England Journal that you'd like to share?
Yeah, so ultimately, the impact that we had, I described the hospitalizations and ER visits. Uh, we also decided to study parity. And the way that we do that in the United States is through the Social Deprivation Index, which is an established index through the United States Census Bureau. now known as the Area Deprivation Index. We didn't actually ask patients something so sensitive as their income information, but you can glean this from demographics averaged by zip code. So it's an extrapolation of a zip code where a patient lives. And what we found, as one might hypothesize, was that now that we did this intervention to uh, have cooperative care delivery but across geographies, we take care of a far more socioeconomically diverse population. I had a feeling over the years, it's always been a thorn in my side, that we take great care of wealthy people. We take great care of you if you can drive a couple hours on a Wednesday morning and come see us during business hours. Um, I had a feeling that that's what was going on, and so it was nice to be able to prove it. And I should qualify, Tomas, that these numbers prior to the intervention, we're talking about an N of about 2,900 patients. And after the intervention, the N on the study, it was in about 1,900 patients. So we didn't study 40 people here. We've got
Yeah,
a couple thousand in each group. So it was a pretty well-powered study and it was nice that the New England Journal of Medicine Catalyst was able to recognize it.
that's exciting. I mean, that's a very solid sample size, so you can be fairly confident that that's an accurate representation, and everything you're saying makes so much sense. And I can imagine the peace of mind that must be going through your head in terms of how rewarding the work that you're doing in Syncora Health is, knowing that those people that are traditionally from demographics that would struggle to get that healthcare are actually getting a chance for one. So I can imagine that being, if that's not a reason for clinic owners to consider implementing cooperative care, amongst everything else, I don't know what it is.
No, I appreciate that. It's profoundly rewarding. I'll never forget that meeting when the research team, the Henry Ford Health research team, we all got together and had our initial viewing of the results. We honestly teared up because we knew something good was coming, but we didn't know that it would reach such statistical significance. So that was very exciting. And just to address the earlier question, I think you asked me just a minute ago, as far as others who are leading clinics and how they might be able to do something similar, I'd say that the first thing to do is, if you are the physician or the provider, then think about it. But if you aren't, then connect with those leaders, because they're the ones who completely know what other pieces of care does this patient population need, and how could we possibly make it easier for them? Because sometimes I always feel terrible when I wrap up a clinic visit and I say, well, we're going to send you to these 4 other specialists and you've got these 4 tests to do. Kind of just gave them a ton of work to do. And we know that they might not execute all of it because they've got their own lives. They're busy. There might be financial challenges to that. So I always think to myself, that's a ton of work I just gave my patient. What could we do something to make it easier for them so that healthcare wasn't such a total mess and we could bring it together better for them? That's kind of what I spent a long time thinking about, to then create these models so we execute care in a more streamlined fashion for our patients.
I love that. As with anything, reducing the friction between actually, it's all well and good saying, hey, do X, Y, and Z, but it's kind of like personal trainer asking someone to, hey, to say, hey, follow this gym protocol. Oh, by the way, I understand the gym's 100 miles away, but go figure it out. Like,
Yeah, I'm sure you'll overcome that. Have a good one.
yeah,
Good
it's a
night.
priority. Yeah, if it's a priority for you, you do it.
Yeah.
Ignoring the fact they have their own lives.
Right. Right.
Bringing it back to work you do at Syncora Health. What are some common challenges that? Because again, I just want to make sure that listeners of this podcast, whether they get to work with yourself or actually um, implement any of these model cooperative care models, that they have some actionable insight in terms of how you maybe have struggled and kept fighting forward. Are there any challenges that you've encountered that you'd like to share when implementing cooperative care models, and how did you address them?
It's a great question, Tomas, because that's part of the reason that I founded Syncoro Health. What the biggest challenge over those years when I was in my leadership at Henry Ford Health, the biggest challenge was gaining the trust of the rural healthcare organizations where we were trying to share care. The branding of any individual, the that badge, that institutional affiliation gets in the way. So what I learned in that time, Tomas, is that this type of work is best as executed by a third party organization that did not have an affiliation with either the specialty service, the specialty organization, or the rural organization. Connecting rural to urban healthcare is another way to look at the cooperative care delivery, since, as I described, a lot of the multidisciplinary um, care does go on there. But a third-party organization that has no affiliation is, I think, the best way to execute this type of cooperative care delivery. So that's the main reason for which I founded Syncoro Health in 2022, is to lead this as a nonpartisan third-party organization to connect rural and urban healthcare. That was the
Great.
biggest challenge, to be honest.
So, in a nutshell, I mean, for lack of a better word, I'm not going to say ego, but inevitably, there's your guide's going to be up if you're asked to partner up with another business owner, and you don't have that level of trust. Would it be fair to say that in a synopsis, by having that neutral third party, you can kind of bypass that potential um, resistance, because obviously Sakura has the evidence. Would that be a fair way of
And
rephrasing?
I think that's fair to say. There were so many conversations where initially I was greeted with, "What are you doing here, Dr. Kaur? We know you're just here to make money for the organization where you are," rather than, "Oh, you are here for our community." It took many conversations sometimes to have anyone recognize that we truly are doing this for the good of the patient. And I think it speaks to the earlier discussion we were having on the fact that healthcare is very siloed, and organizations, understandably, in this climate, are very focused on their own financial benefit. Understandably, healthcare is very challenging these days. Costs are extremely high. So bringing it back to the patient focus and community focus is can be an unusual conversation, especially for a business model. So that is why I think a third party, unaffiliated organization is the right way to execute cooperative care delivery for the good of the patient and the community, crystal clear right up front. And to piggyback on that, when you think about, well, whose responsibility is that? Who should be investing in that business model? Who should really care? I do turn to the federal government for when I think about where that responsibility lies, and I'm wildly excited about the ARPA-H agency, which stands for Advanced Research Projects Agency for Health. This is a sub-agency of the United States Department of Health and Human Services. They have a number of profoundly well thought out programs that have been funded by the federal government to execute improvements in healthcare. So we are actually turning to ARPA-H to fund portions of this endeavor.
It's exciting. That's really exciting. In terms of so you talked about, also sorry, how are you set for time, Nirmal? By the way, just
I have a 9:30, so we're at
uh,
5 minutes, but we're good.
we got 5 minutes. So that's a quick question. We'll ask where people can find you. Uh, what do you see the future looking like for cooperative care models in the next
You know, I
five,
think
10 years?
5, 10 years. So we're already starting to see the consolidation of healthcare, right? The mergers to cut operational costs are going on everywhere. We are starting, or the beginning of the tip of the iceberg on the shortages coming, right? If you look at the AAMC data, the projected shortages of physicians, it's awful. So we are going to have no choice but to enter into cooperative care delivery in the very near future. The level of struggle that's seen financially will lean on this model and benefit from this model because of that new music coming in, those new patients coming in, because we'll be able to improve access. So I think a lot of the bumps that we see in the Becker's headlines and the modern healthcare headlines, those are going to unfortunately continue on. And then I see cooperative care delivery as being a portion of the solution to allow for healthcare delivery to be sustainable, both for patients' health and for financial sustainability of these organizations.
Exciting. Well, pity there's more shortages, but at the same time, if only we knew a third party service provider that can actually help with these. So on that note, Nerval, where can people find you and find out more about get in touch and find out more about what you do?
Sure. So syncorohealth.com, SYNCORO, Syncoro, um, is the name of the independent consulting firm that I founded just about 2 years ago now. And that is how you get in touch with us. And we're on LinkedIn, of course, and happy to talk to anyone who would like to get started on this in their markets, improve access for patients, and ultimately improve outcomes for patients and communities.
Brilliant. I'll leave that in the show notes. With that being said, Nermal, I know you've got call initially 2 minutes, but it's been an absolute pleasure, and I'm sure we'll do this again. Looking forward to the next one already. Thank you.
Thank you, Tomas, for the opportunity. Been a pleasure to chat with you this morning.
Likewise. Bye bye.